Trey Sutton here, and I'm glad that all of you had a chance to join today for such an important conversation. I'm incredibly grateful that Dr. Battle and Danielle have joined the conversation. Kim and I have been teammates before, as LaDonna and I have been, and so we're excited to be with this group today. What we wanted to do is just start with some introductions. From there, we'll go into a survey that SIFWell did that reflects the voices of people across the country and how they perceive and experience the healthcare system. It's going to be an interactive conversation. From there, we'll move into a little bit more about how technology and some practical approaches can be used to address some of these issues. And that's really why we wanted Danielle, LaDonna, and Kim on the call today. They're on the front lines of this work, and they will be able to bring exactly that perspective to the conversation. So with that, why don't we start with introductions? We'll go LaDonna, Kim, Danielle, I guess. How about that?
Okay, sounds great. Thanks, Trey, for the warm welcome. I am Dr. LaDonna Battle, and I am the Executive Vice President for Care Management and the Chief Population Health Officer at Trillium Health Resources, located in North Carolina. We have lots of amazing things that are happening within this landscape, and I'm excited to share with you some of those things that are member centric today.
Good afternoon. I am Kim Webb, and I am the Vice President of Health Strategy. I'm excited today because I've had the opportunity to work with all of the individuals on this panel. Danielle Brooks and LaDonna are former colleagues of mine, and now they are friends. So it is just a thrill to be able to talk with them today about this important topic.
Well, last but not least, my name is Danielle Brooks. I am the Corporate Director of Quality and Health Equity in the Amira Healthcare family of companies. Kim and LaDonna has already said what I would say, but it's really wonderful to be here to discuss not only this report, but how we can take this information and turn it into action. So thank you guys for having me.
And Danielle, we actually saved least for last. My name's Trey, and I'm one of the co-founders at SIFWell. I spent a bit of time working as CEO of a mostly Medicaid plan, and then was CFO of Medicaid North Carolina. So been working on a lot of these issues for some time now as well. And so I appreciate the three of you jumping in. Kim, why don't we start with you and just tell me when to advance, and let's go through some findings and have a conversation.
So before we get to some of the slides, I just want to set the stage of what our audience is going to hear about today. Um, SIFWell, this webinar is delving into SIFWell's inaugural Health Equity Index survey, and that can be found on the SIFWell website if you want to see more information about it. This survey focused on illuminating the experiences and the perspectives of Medicaid eligible populations regarding healthcare access and health equity. SIFWell is surveying members nationwide and bringing those insights to our insurer partners to help support their efforts to connect and improve the health of the members. New England was our first region that we focused on. So you can go to the next slide, Trey. What you're going to see is that the report reveals at large individuals that are eligible for Medicaid in the New England region feel they face unequal quality and access to care based on their race, their sexual orientation, or their disability status. Unfortunately, many of these findings will not be surprising for many of us on the phone, nor are they unique to New England. With a razor sharp focus on understanding this report's insights and applying the findings to their unique regions and circumstances, community health insurers can more confidently allocate their resources to build a more inclusive healthcare delivery approach and also reach their health equity goals. So, as you will see, the State of the Union, again, new but unsurprising findings. We find here that 51% of New England's Medicaid population have faced some type of health inequity. On the right side of your screen, what you're going to see are those attributed factors where people feel they faced an inequity due to their mental health status, due to a physical disability, a mental disability. Sometimes we call the mental disabilities invisible disabilities, their chronic disease, their race, ethnicity, gender, maternal, child, face discrimination due to that or their sexual orientation. What you'll find here is that in the data, 31% of Hispanic and 29% of white respondents most frequently attributed inequitable care to their mental health status, while Black or African Americans contribute 25% cited due to their race. So, again, these are not surprising findings. So some of the top line findings that we saw in the literature, I think I'm on slide 3. Yes, around income and race are perceived to be the most detrimental of the factors affecting quality of pregnancy care. So, as you can see here, 51% of our respondents said quality of pregnancy care is impacted due to my race, my gender, my sexual orientation, disability, or income. 46% of individuals who identified as LGBTQ said that they or their partner have experienced difficulties with pregnancy, and that's a 15% increase over their peers who identify as straight. And then 37% of people of color stated that their partner or themselves have experienced difficulties with pregnancy during their pregnancy when they're trying to seek care. One of the things I want to highlight here, and I'm going to go to Dr. Battle first, is we have here that representation matters. 11% of the respondents said they were more likely to agree that it's important that their pregnancy healthcare provider is of the same race, ethnicity, gender, or sexual orientation. What Dr. Battle didn't say is that she is an APRN, an OBGYN. And so, with that, I just want to get your opinion, Dr. Battle, when you were practicing as an OBGYN, advanced practice RN, what was your experience with that?
So thanks, Kim. I think when you say presence matters and seeing someone like you matters, I think it goes beyond just looking at race and in that regard. They really, in my practice working with the perinatology group, they really, the members that we engage really wanted to know that you that the person understood them. It's easy to write a prescription or it's easy to give recommendations, but do you understand the background that I come from is what the members would say. And do you understand, are you in touch with all the things that we call now social determinants or our unmet needs that make it important for me whether I'm going to engage in your treatment plan or not? And so having members, I practiced in an area which was high poverty area. Some people would call it, uh, I'll say the area where um, most members were Medicaid participants at that hospital and facility, and even to the point where the doctor and I had to do home visits because of the socially unmet needs. We couldn't get people into the office because of transportation. So we decided that we were going to go to them in their homes. And really, once we saw the environment that they lived in and the resources that they needed, it changed the level of practice and it got buy-in and ownership from those members or participants because they really understood that we got it. So I think that's what anybody really wants. They want to make sure that the person is connecting with them and not just spitting out to them, this is what you do for practice for my treatment plan, but this is how you integrate the treatment plan into my daily practice of life.
Thank you for that. Very insightful. Sure, can we go to the next slide? So barriers to preventive care. Not surprising here when we survey the respondents in that New England region, they cited long wait times and scheduling difficulties are some of the main factors in them at being blocked at preventive care. You'll see 22% cited long wait times, 22% cited work schedules. And over on the side here, it talks about poor experience or further deteriorating care. 18% of white respondents surveyed said they experienced unfair healthcare treatment, while 30% of our non white respondents indicated that they or someone they know has been treated unfairly. 25% of the respondents reported struggles with not being believed or listened to by healthcare providers, and nearly 1 in 5 experienced a language or cultural misunderstanding when they sought care. Danielle, as the corporate director of health equity for AmeriHealth Caritas of Families that spans over 10 states, I'm sure you see quite a bit of this when we're talking about difficulties and barriers. The states span the Northeast region. There's New Hampshire, the Southeast, as well as the Midwest. Can you expound on what your experience has been when you look at the data and you see what is blocking or preventing individuals from being able to seek equitable care?
It's very multifactorial. And one of the things that really jumped out to me about this data is that while I know this is really around the Medicaid world, actually research shows that independent of your geography, your socioeconomic status, or your income, race is one of the highest indicators on if you're going to be treated respectfully and listened to. And it's endemic. So I'm not necessarily surprised by this. If you take language as one of the first kind of aspects that kind of jump out at me, that's one of the most basic foundational components that we really need to make sure that are in place to make sure that we are able to communicate to the folks that we want information to come to. If for anybody that's ever traveled in a country where English is not predominant, as the language, you know how difficult it can be to navigate that space. And that could just be from getting around or transportation. Now put that in the instance of your healthcare setting. And there's a lot of system reasons for this. In order to get proper language translation, you have to have staffing availability. You have to have services availability. You have to have diversity of medically trained folks. So I think there is a pipeline issue with language and also an education issue on really that importance of that connection. In terms of not being listened to or being heard, we see that throughout multiple practice areas. We see that in maternity. We see that in chronic care conditions. And it really is an incredibly crucial point of patient-centered care, but also making sure that there's true value in your care and effectiveness in your care. So I'm not surprised by this information, nor does it really differ that much in a lot of different conditions. We also have issues of incredible medical deserts. We see that very frankly, especially in the maternal space. Medical deserts are growing, hospitals are consolidating. And that often happens in areas that have been systematically deprived of economic mobility. So there's definitely a through line of what I would call anybody that has been historically discriminated against and the effective healthcare access and the effective healthcare quality.
Yeah,
Thank you for that, Danielle.
yeah, just jumping in just for a second, Kim, because I think that the two threads that Danielle and Dr. Battle have begun to talk about is also exacerbated when you're talking in terms of mental or behavioral health services and physical health, where on the behavioral health side, it doesn't necessarily manifest by way of a blood panel or something else, that it really is being listened to, being heard, being understood, where that, if there's not data necessarily available in a chart or in a test or in a diagnostic, it's ever more important that the cultural concordance piece is there. And I think that's something that in working with you, Dr. Battle and Kim in a previous role, you really brought to the surface for me. And now it just feels so obvious, but working with individuals affected by mental health conditions and other like situations. I wanted to highlight that point as well. And Kim, I would love for you to add anything that you'd want to there.
But, I think in one of the previous slides, we talked about mental health disabilities, and I call that the invisible disability. And
Yeah.
so oftentimes you don't know, nobody's wearing a sign that says I have schizophrenia or bipolar or major depressive disorder. And so they're going in and they're describing their symptoms. And, we've all heard it, whether it's on television, in the news, a friend, the provider may say, oh, well, it's all in your head, right?
Yeah.
That's not really happening. Yes, it is all in their head. That it is their mental health, it is their rumination. So I think individuals who are battling, have maternity, and also um, facing mental health, they have a double challenge. And then add on to that, you're a woman of color, right? And then add on to that, you're of low social economic status. Is challenging. And so you're not believed, you're not heard, and quite frankly, it's frustrating. And oftentimes we say, well, why aren't they going to the provider? Would you go to a provider if every time you were ostracized or questioned about how you feel? And if what you're explaining, if it's true or not, you probably wouldn't go either. So it's uh, more than a double whammy, it's triple, it's quadruple. And as a country, we need to do better.
And may I also add, I think there's also this, to add to the layers of invisibility, there seems to be normalization of level of trauma depending on your culture.
Mhm.
And there seems to be a normalization of levels of trauma based on your socioeconomic status. So I do think that we also have to be very open and honest, especially when we think about our expectations. We can even take gender as an example. I'm a new mom relatively, and I'm very acutely aware of, the pressures a new mom has on still maintaining a career and holding down the house and being the emotional support person. There's a normalization of stress. There's a normalization of anxiety. So oftentimes, especially when we have these populations that have been historically discriminated, there is a baseline normalization because that's the day-to-day life. So it's so very critical that as we seek to really get connected with providers, whether it is for behavioral health or emotional support or physical health, there is an understanding of how these systems do impact us, how history impacts us, and contemporarily. And so when we talk about this idea of cultural competency, I think where people get lost is there's a belief that there's a certain way, particularly of care, based only on my physical race or my gender or my gender identity. The reality is it's also coupled with what does that experience look like? What does that disproportionality of experience look like? And that also is a foundation of cultural competency or responsiveness that I don't think enough people kind of pull into their practice as well.
Yeah. I want to add to that because from my experience along the way, along the continuum of my professional journey, I had an opportunity to be the health administrator for 14 community-based centers. And we were focusing on HIV, and it started with the maternal population, but quickly moved over into a strategy for men's health. But within that area, there were 14 different clinics in 14 different areas of the state. And each one of them had a different ethnic and social makeup based on the community we were in. So if we were in a predominantly Haitian populated area, that message had to be tailored to the men and women there. When we moved over, that same curriculum had to be tweaked for our Asian population, as well as the African American and the Caucasian and Russian and what have you. So there was an example where we developed one curriculum, but quickly realized we needed 14 different modes or modules in order to communicate the message to get success there.
Yeah, and I think it was notable. You can go to the next slide, Trey, that your center took the time to craft those different messages. We talk about health literacy and we wonder, well, why aren't people getting the message? Oftentimes it's because we haven't taken time to deliver a message, right?
Mhm.
And so all of this very, very relevant. So also in our survey, we looked at financial issues. That remains the biggest barrier to mental health care. I think we touched on that in the previous slide. 44% of the New England Medicaid-eligible respondents say they have been diagnosed with depression, and 42% have said they've been diagnosed with anxiety. Trey stated that LaDonna and I worked with him at a previous organization, and that organization was focused on behavioral health. We were behavioral health MCO. And one of the reasons why I went there is because, as a nurse, having done um, case management, very focused on physical health, there was something missing. We were engaging with members, we were doing the standards of care, putting all these interventions, but there was something missing. And what was missing is that we were not diagnosing, not picking up that individuals who had these chronic diseases, um, weren't treating their depression. And we didn't pick up that they had anxiety. And so this was, of course, during pre-COVID and during COVID, but there was that stigma
Mhm.
there, right? And so one of the reasons I wanted to go work at the organization where Trey was the CEO and LaDonna was the VP, is because I wanted to understand it more and wanted to understand that system of care around mental health. But you'll see that access is still a challenge even post COVID. It is significant for all of the entire all of us as Americans, but more so for our Medicaid eligible individuals. You'll see here by state within the region, Maine 47%, New Hampshire 35%. And so mental health and equities are still a significant barrier for many who are seeking care within the Medicaid population. I'm just going to open it up to all three of you because
Mhm.
you've all worked in this space. What would you say about the financial issues and still having this very stark um, difficulty getting access to mental health services?
Well, I'll start off. And from my perspective, we need to look at access to care as a factor of availability to care and the stigma of care. And so, if we look at it from those vantage points, we understand what interventions that we need to do in order to make inroads with this population. COVID has taught us that we need to shift and focus on mental health even more so than we thought we were doing in the past, but also to bring that care to telehealth became an opportunity that wasn't there because we had barriers and regulatory requirements and all of those things. And then COVID came and taught us that all those things are immaterial. Get the care to the person as quickly and as effectively as possible because they need it. I think when we look at the social aspects of care, yes, we have our members that are in Danielle talked about deserts. We also have deserts of mental health pockets where there are no psychologists, or even resource clinicians to help, or even lay persons that can direct care. We have pockets of that. And so we need to do better about that. And then those that have means, how do you make sure that those things are available and timely, so that they can um, work that around either jobs or other priorities such as family life and so forth. So I'll stop there, but it really opens your eyes to things that need to happen on the ground level.
Yeah, I think that as a country, we've under-resourced and undervalued behavioral health for far too long. We know that it's one of the highest, along with heart disease, contributors to poor maternal health outcomes, especially for African Americans. I think that it's very strange that as a country, we look at behavioral health access as almost a privileged service. And we often divorce it differently than we would from a physical condition. But just as you may break your leg, it is so critical to make sure you are treating anxiety and depression and any baseline trauma or PTSD. I think it's very strange that as a country, we almost collectively forgot the trauma that we've all gone through 3 years ago at the height of this pandemic. And that really confuses me. But with that stated, I do think there is a knowledge gap of your available options for this population. Oftentimes, people get connected with behavioral health services precipitating or following a serious mental health crisis, and that's usually the tie-in rather than knowing that it is an honest benefit. I also think that we need to do better connecting our physical health needs to our behavioral health services more seamlessly. And that's holistic of the way Medicaid is organized in the state level. Sometimes it's a carve out, sometimes it's an included benefit. But for example, we know something like diabetes. If you're self-activated, there has to be a sense of wanting to support that to be successful at your diabetes condition management. But oftentimes, diabetes is a comorbidity with anxiety or depression. And so I think it's just very important that we consider that need, really kind of think about how it's carved out and how it's structured at those levels, but really kind of spread that message that this is a benefit and really look at that recognition of how it does couple with other types of chronic physical conditions.
Yeah, I mean, I agree with everything that's been said. I mean, the other thing that's always on my mind, coming out of the Medicaid world is, to Danielle's point, it's like after that first psychotic episode, the subsequent ones happen, more frequently and are more devastating. And what we know now is that for a lot of chronic progressive disease states on the physical health side, the precursors are existing, and we see them in the claims information going back if there is claims availability there or if the person has that access. And so we often see some of these mental health conditions as precursor for physical health spend, and we're treating it very much like we do writ large in this country, which is reactive care. We're going to get into a little bit about the work that SIFWEL is doing later. But a major goal of SIPWEL is actually to surface those things much earlier so that we can get ahead of these things. And I don't want this to be a SIPWEL commercial, but this is an area of healthcare that I'm incredibly passionate about. We have to do a better job because all the macro trends are moving in the wrong direction. We've got less and less people entering into medical education, not only doctors, but across the field, in areas where we need them the most, like primary care and behavioral health services. Outcomes are staying flat or going down, and costs are going up. And so we've got to do a better job, and where there's opportunities to introduce technology, I think we need to do that as a country. So.
I think everything that you all said segues us into what's working, services, and use. So, as we look at this slide, our respondents supported the fact. I always say, think globally, act locally. Healthcare is an activity that is best done locally. So you'll see here that state local support programs are being utilized by this group of individuals, these 1,700 individuals that we surveyed. Access to care is improving. So although we have a long way to go as a country, we do see there is a beacon of hope. There is some light at the end of the tunnel, and I think we are trending in the right way. So here you have mental health care. 45% of people report feeling that access to mental health is getting better in their communities compared to 5 years ago. So that is right before we went into the COVID pandemic. For African American respondents, were more likely to agree with that. So they're using their mental health centers. 29% are using their mental health centers. 27% said that they're using crisis service resources like crisis text line. I know at AmeriHealth, we were always going back and forth about texting, and we text a lot. And we felt like, well, that's only for a certain demographic. Here it says 18 to 24, but we also saw that people, Medicare, they're pretty tech savvy, that Medicare population. And so they were responding to text messages. It's nice to have a reminder, or when you are in a crisis, being able to text. Sometimes, talking is just not what you want to do, but people will text. Is almost a new way of journaling, if you will, for some of the younger generation. So centers seeing the highest usage of 58% of the Medicaid eligible New Englanders have used or do use local services. 21% say they would consider it. 16% of the LGBTQ community are more likely to use the services than their straight counterparts, and 10% of women are more likely to utilize state and local support. So this supports what I've always said, is that we have to invest into our neighborhoods, our communities, into our local healthcare infrastructure, because that is where care and that's where people live, that's where they work, that's where they sleep, that's where they worship. This is very important. So, I want to see from our esteemed panel, what would you say about this? Danielle, particularly, I want to go to you first. There's plans that you're overseeing in the Northeast, Southeast, and Midwest that I've stated earlier. But how do you see local care and state care? How does it differ? And are there some states that are doing a better job than others in your work at AmeriHealth?
Well, I'm not going to put any state on blast. But
You can just say the region. No.
uh, region, yeah, I think that northern regions sometimes do a better job than southern regions. But there's history there, right?
Mhm.
So there's history of infrastructure, and I don't mean to sound like such a historian, but I do think that when we talk about these issues of equities and disparities, we have to put it in full context because it is so tied to politics, it is so tied to economic development, it's so tied to legal pieces that it's very hard to divorce. I think the phrase of community resources, community spaces is such a powerful thing. It indicates it's where you are, where you live, where you worship. It's where you are, this is where you define yourself. So if we think about really systems where we can build trust and support and access, having those resources is an indication of the health of a community. Having a space where a medical system or a state or wherever the infrastructure is coming from invest in that is a signal of the value of that area. I think, unfortunately, we're seeing so many closures for multiple different reasons and so much instability in that access across the nation, where rural areas are being predominantly affected, but not always, because also in urban areas, certain centers are closing. I can give DC as an example. You can only give birth in one half of the city, the other half you don't have. Um, so what I'll say to this is that yes, I don't know what more to comment on that, but yes, having access to health in your community is important. It helps having the providers come from your community, understand the background. There has that innate sense of where resources may be missing. It has an innate sense of why you may not be able to get there on time because maybe the train never runs correctly. It has an innate sense of this may be an area suffering from more violence or more deprivation in another area. So it is in a way building your cultural responsiveness because again, it is about knowing the context and how people live, not just where they're from. There's two parts to that dynamic.
Thank you, Danielle.
So,
Anything you would like to add, Dr. Battle?
Sure. So I'll tell you, coming off the heels of a recent population health assessment that we completed in July of 2024, um, within our organization, we expanded from almost double to from 18 we added 18 counties to make us have 46 counties. So out of North Carolina, out of 100 counties, having 46 counties is a substantial footprint. So in having those new counties join us, we had to learn about the dynamics of the counties, so that from a behavioral health, mental health, behavioral health, um, integrated care with physical health and social determinants, we could really understand the communities that we were serving. So, in so doing, we worked with a partner, and they were helped us to do not only the regular demographic evaluation, but also to get in there and meet with our local community leaders, our community advisory groups to see what their priorities were. Also, working with our health equity councils and also looking at it from diversity and inclusion, population health, and quality standpoint, we were able to pull some work together to help us to understand down to the level of our counties and even zip codes where our members that needed us most reside. And then we've started to plug in our interventions, program expansions around that. And the SIFWEL team, and I guess as a segue, unintentional, is very instrumental in that next step of helping us to prioritize those members that need us most from a risk stratification, as well as from looking at them as cohorts of members that could benefit from our services the most. So I'm excited by that, but it really tells you that you have to know your community so that you can give them the resources that they need and not just say, this is plug and play, whether you need it or not. It's not beneficial to anyone.
That is a great segue into the next phase of this conversation where Trey's going to be going over how SIFWEL does support community insurers and ensuring that they understand. You know, we've talked a lot about understanding, and so I always say equity begins with empathy. Understanding who it is that you're serving, your populations, their cultural needs, just who they are, that whole person care, who the community is, and then the equality around it. Danielle, you talked about the historical piece of it is something that has to be taken into account because it has shaped the policies and the infrastructure and individuals living in disadvantaged communities or being underrepresented in certain professions. So, Trey, we'd love for you to talk to us about how the technology and the analytics that SIFWEL provides to our community insurers can help them reach the pinnacle of health equity.
Yeah, thanks for that, Kim. And LaDonna, that was an incredible segue. And it actually wasn't planned to the audience. It just worked out incredibly well that way. And, LaDonna, we appreciate the partnership that we've had. This is really about accelerating the understanding of members and then understanding exactly what are the types of supports and services that are important. I'll touch on this one briefly. This is a quick overview of the risk stratification piece that Kim mentioned. We work with a partner to identify some emerging risk individuals. The left-hand side shows our performance as compared to another risk stratification tool. And what you can see there is that on a back-tested basis, we were able to identify significantly more in actual cost of members. But more importantly, from my perspective, was that we're identifying non-traditional segments of the population that are emerging in risk. So these aren't your traditional cohorts, older white males, for example. These were non-obvious segments of the population that were coming out for opportunities to support and intervene. On the right-hand side, you've got individuals that the other tool labeled as moderate that actually ended up being very high risk, and they were part of the cohort that we identified. And that's in part due to the additional information that SIFWell brings in. The quick version of that is, we start with our health plan partners, claims information, eligibility, and network information. But to that, we marry over 15,000 data elements. So we know about languages spoken, income, education, age of homes, family structure, access to transportation. I mean, you name it, we know it. And that becomes the data corpus. And so you're looking at a lot broader set of information that then you can contextualize members. You're not going to be 100% right, but you're much further up the learning curve about the members that you're supporting and the information that you should know when you're reaching out to them to engage them. And so that's one of the really important things that we do with our plan partners. Once we use that information and make some predictions about who's emerging in risk, we go in and really explore those. None of this can be black box, and so we really want to understand what's happening and why these predictions are being made. And so in this instance, we're really drilling into one cohort that emerged naturally out of the machine learning. And what we've got here is roughly 190 members. They're going to move from roughly $800 to almost 10 grand in cost. Predominantly, these are females between the ages of 18 and 44, relatively new members to the plan. A good portion of them are expected to be diagnosed for the first time with type 2 diabetes over the next 12 months, but they're also showing up as being high risk for some other conditions like hypertension, obesity, and lower back pain, and so on. And then on the right-hand side, what you're seeing is additional contextualization, and this is some of the really important stuff. So, we've got some issues with this group around low medication adherence. They don't have access to broadband, and so an email campaign probably isn't going to do it. They're also running up against some transportation barriers. But they are interacting with a system. So we've got an interception opportunity. They're presenting in a PCP setting higher than some of their peer groups, and so we've got an interception opportunity. So that gives you a flavor for some of the work that we do with LaDonna and some of the other organizations within the ACAP world. LaDonna, what would you add here? Anything?
I would say this information is so valuable to the frontline care manager. When they get this information, they understand exactly what they need to do for the member. It helps us when we go one step up to looking at our intervention strategies of what kinds of network resources we need to put in place, where we need to put them in place. Also, looking at building out and building up some of our programs that are on the shelf. How can we tweak the program to make it relevant to one county or region versus another? So this information is used at every level of our organization, even up to looking at how do we develop our goals. And again, I have to say we have a 4-pillar approach, which is quality outcomes, not just checking the box, looking at it from a diversity, inclusion, population health, and also a health equity lens. So this informs all 4 of those strategies that work together in our organization.
That's great. Thank you, LaDonna. All right. This technology also works with very limited information. I mean, one of the things that we talked about was limited access to claims information. What you're seeing on the screen here is our ability to just, with 31 days of information, do a much better job than random for targeting and outreach. Now, the other important thing to mention here is that the work that SIFWell does is principally in the areas of identification, diagnostic, testing, prevention. We're not doing care pathway decisions. There's a lot of risk associated with that. You don't want to make the wrong choices for medical care. And you also obviously always got to keep the human in the loop for review of these things. This is a piece of the presentation layer, and often where things begin is what we've identified here is some individuals that are going to rise in terms of cost relative to their current cost. But the thing to note here is that the motivation isn't cost reduction. The motivation is avoidable or unnecessary spending, and so that can be redirected into other members or other community programs. So I want to make sure I mention that. But that's essentially what we're doing here. And what we do is on this next slide, what we're doing is something called data twinning. And in this instance, we're monitoring the impact of a certain support or service down to the individual level. And the way that we do that is by simulating randomized controlled trials over historic periods of time. And so what we find is basically two individuals, one of them got a supportive service, one of them didn't get that support service, but it was arbitrary in nature. In fact, these two individuals looked identical in every observable way. It's just that maybe the service wasn't available in that particular geography, or their care manager didn't know about that service. But essentially that's what's happening here, simulated randomized control trials. And so what we're doing now is taking a look at the impact of getting somebody connected to a PCP visit. What you can see is that from an impact base, to understand the associated utility of certain interventions for specific individuals for assignment to those programs. So that's essentially what's happening here. And I will leave it at that. So Kim, what would you add? Have you been on the front lines here and used some of these tools and been in a ClinOps role?
I think this information is very insightful. LaDonna talked about this tool has been very helpful for her. And I think for integrated teams, it is very important. We spend a lot of time in care management, whether it's your clinical or non-clinical team, trying to sort through what is best for the member, doing chart reviews prior to calling, whether it's the initial call or the follow-up call. And what I like about the analytics, and one reason I came here, is that it's helping point us true north, right? What are those targeted interventions that are really going to make a difference? So a lot of the inputs that we have are centered around the member. We talk about whole person care, we talk about targeted approaches, but I don't know if the industry has really moved to ensuring that the inputs that they're using for their data really is focused on the member. And so our data science team has done a Herculean job at pulling in tens of thousands of data inputs to have a true representation. Earlier in this call, we talked about representation matters. And so it's not just about who they go in and see, but the data should also represent the population that we're serving. So I think it's been very helpful. Many of our clients, other than Trillium, have found that it's been helpful, and it's allowed them to better understand who they are serving, um, and how they should serve them, and what they are going to respond to. And so when we say that adage, meet your member where you are, where they are, that really begins with your data, right? So not just where do they live, but what newspapers do they read? Where are they shopping? When are they going to respond to your phone calls? And so all of that is important if we want to really do true member engagement and meet members where they are.
Essentially what you're seeing here is exactly the same bubble chart with the data twins. As you go into it, if you click on one of these, what we've got is 66 members, and what we're trying to understand here is the impact of getting a very targeted group of individuals to a PCP visit in the most accelerated fashion possible. So here we're going from big data down to small data. Let's focus on these 66. Let's get them connected with PCP visits. And again, the yield from this is a potentially reduction of avoidable cost of $470,000. The goal isn't to reduce cost, isn't to reduce care. It's to reduce the type of care that none of us want to members to experience. And if you look on the right-hand side, what you see there is the number one driver of those additional costs is ED services. And so what we're trying to do you don't want a family member there. The member doesn't want to be there, and the plan doesn't want to have members in EDs, unless it's a traumatic trauma type event. And so that's the kind of the full story there associated with that particular use case. So I will stop sharing now. So I think that was the most of what we were going to cover. Danielle and LaDonna, any reactions to any of that or questions from the audience?
No reactions at this time. But I do appreciate where you guys are moving in terms of these multi-points of data. I think oftentimes a member's journey, a member's experience, a community's experience tends to look like a linear piece. And I think it's so critical to be able to see that intersection of inputs. So no questions, but I do always appreciate that kind of information to help drive change.
Thanks for that, Danielle.
I will say as a final word that before I had this data, I felt like I was driving the airplane or flying the airplane blind. And when the data sat in my lap, it was like, oh, I can do this, I can do that. It really opened the door for all the possibilities, because it laid out so many different opportunities for us to explore. And so sometimes my team has to say, slow down, you're taking us too fast. But it's all in love and passion for the members that we serve. We've been slow for so long that we need to move fast and put our foot on the pedal and help us to get there in a meaningful way.
And I just want to say it's been a pleasure working with Trillium. We are supporting them in their NCQA
Mhm.
accreditation. So they're using our analytical insights as they march towards that goal, and we're partnering right with them. So it's been fun to watch this plan move towards that end. So we're with you all the way.
Thank you.
Good. Well, Dr. Battle, Danielle, Kim, I really appreciate you taking the time to share your perspective and thoughts on a super important issue. Thanks to everybody that joined. We're easy to get a hold of if you've got follow-up questions, and thanks for taking time.